Now, there are not too many questions, but I'm sure there are a few things we can quickly discuss. Actually, this is a question by an anonymous attendee. I think, Yan, you might as well take this question. It says, for medical legal reason, do you record your POCUS images, one, and when things head south, would the committee mandate POCUS accreditation by the physician?
It's
What's
a
your
very,
thoughts?
very good question, and it's an emerging area. Currently, there's precedent in emergency medicine. Looking at what their pathways are, the anesthesiologists have set their numbers and aspirations higher. In terms of recording all the images, do I record them? No, because it is an ongoing IT issue, even in Silicon Valley, to get that organized. But there is a hospital-wide effort on having that happen. Again, the emergency room has precedent. They have things set up where they don't record all the images, but the images that they record, they can either go for educational or billing. If you bill, then you have to obviously probably record it, write a report, and all of that. But they do have a proctoring program, but that's one of the things that at least our hospital is starting to look at, and one of my projects that are going on.
Thank you, Ian. Next question is to you, Shah. Now, when you look at ultrasound of the lung, if a novice were to start doing ultrasound of the lung, how long does it take for an individual to become proficient? I'm not saying quantitatively, but in terms of qualitative images of recognizing pneumothorax, pleural effusion, or even for that matter, to find the, diagnose things like pneumonia and consolidation. What was your experience?
I think the different signs some signs are easy to pick up, and it's probably as we're learning it, just reflecting on my experience as well as the experience of my trainees. I think, for example, the B lines are quite easy to pick up, as well as some degree of alveolar syndrome where there's consolidation. But with regards to the pneumothorax, in fact, even in the 2012 recommendations by the Wind Focus Group, they did mention that actually it's actually a difficult ultrasound examination because of the fact that it's a few flows in the 4 signs that you're looking at. So to answer that, I think for the pneumonia, pulmonary edema, it's probably about 10, you probably get an idea of what's going on. But with regards to a pneumothorax, it's definitely a lot more than that. I mean, I took a while to appreciate the lung point until I was probably, definitely a lot more experience with lung ultrasound.
Thank you. Here's a question for you, Ben. While the ultrasound is definitely a useful tool for some aspects of airway ultrasound, but in the situation when, say, you're in the operating room and everything is heading south, where you can't intubate, you can't ventilate, is it simple to bring the ultrasound and do the cricothyroid puncture or the surgical airway in that scenario?
What I'm saying there is we do lack of experience actually performing. You can get a picture, and then the main thing is I will say that in this situation is quickly that I will say using ultrasound quickly to reconfirm your landmark technique to almost like how we do epidural, find the midline. Like when we have big patient, find the midline, where it go, how deep is it, quicker than rather than people want to using ultrasound with the real-time guided, I think will be extremely difficult because your probe in the way is irregular area. You have to put lots of gel and so forth. So quickly, the best thing is we confirm the location, make sure that, let's say, you're not too high, too low, you avoid the thyroid isthmus so that you don't damage too much, and then find the closest area. With the fake neck, sometimes it will help you like nail down the location, but I won't recommend, at least at current stage, maybe it will be challenging to do a real time. Just like lots of people trying to do the real time thoracic epidural, same thing, we're trying to, after the small area where when you get in trouble, that means that usually in proportion to the body habitat will be difficult.
Okay, so on the same note, is it not prudent if you anticipate a difficult airway and to incorporate it part of your routine is to, before you start your airway interventions, you do the scan, mark the cricothyroid level, and then if you're in dire straits, then it becomes a useful landmark for you to place your needle, whether you use nerve stimulator or not. Then it becomes a lot simpler, wouldn't it be?
Yeah, correct. That's why I mentioned that try to practice more transtracheal injection. You can accomplish with the topicalization, prepare for fiber optic. At the same time, you know that you get in the right area. Another thing that you know that if you put the angiocath into using ultrasound, mark it and put it in, when you inject small amount local anesthetic cough, you know that they're definitely in the airway, and topicalize a little bit, and also can reduce the laryngeal spasm while you do fiber optic too. So you can leave the small 22 gauge there as a marking, but not to just jet ventilate. It won't work, but it will help you to identify location. Circuit marker there will help. But I would say that actually once you do a few times the transtracheal injection, your comfort level become higher, just like how we do intubation. Once you do the feel, you know where is the midline, how we feel, how you hold on to the trachea. First time when I trying to do it, yes, when you don't hold on to the trachea, when you try to put the needle in, the trachea just pop on the side, so that you know not getting it, and the distinct feeling, just like first time when you do epidural, when you get loss of resistance, is quite distinct. But you have to hold on to the trachea well, but don't not go too far on the other side. So practice is important.
Yeah, sure. Practice makes perfect, and I think for point of care ultrasound, I'm sure there is a need for most of it. And on the same topic. This question goes to you, Yan, is you did present some data on, say, a resident after a simple lecture and a few scans were then sent to the ward to examine cardiac patients with aortic stenosis. And eventually, to cut a long story short, the results were not very different from the specialist. Now, we are talking about qualitative assessment as opposed to a full systematic TTE with quantitative numbers and so on and so forth, particularly in the context of an emergent situation in anesthesia. So what do you think would be, suppose you allude to the fact that you can introduce them in, say, resident training programs. How many examinations do you think would make a resident able to pick up most of the views that you have shown with relation to TTE during a focus examination?
Well, I mean, there is am I muted? No, I'm muted. There is another great study where they pitted medical students with 8 hours against board certified and a handheld ultrasound against board certified cardiologists. And they did very well as well. It is not quite that simple. So the recommendation for basic understanding is probably 50 exams, level 1, so performed and interpreted with, ideally as many as possible. with an attending physician has some sort of experience and significant experience, whether it's at least a POCUS certificate or a critical care or whatnot, and then another 100 exams as a level 2 exam. So it definitely is the biggest investment of the core POCUS applications, where sort of I always call lung ultrasound, sort of like, because we're near the chest wall and near the neck, it's sort of like the gateway POCUS exam. But and like all of it, it takes a while and persistence, and QA is another complex topic.
Yes, I quite agree. I quite agree with you that there is need for a lot of practice. But when the intention is good, I'm sure with practice, the skills will automatically become internalized. Okay, in the interest of time, I'd like to thank 3 of you for the wonderful presentations and for making it so lucid and clear. I'm sure it raises a lot of questions. There are some more questions. I think it will fit in better with the second half of the presentations. So with this, I'd like to thank you again for joining us despite being so late at night in Stanford. I hope you stay with us for the next part. But if not, thank you again.